the first thing I want to say is that actually, leadership takes place in all of our organisations at every level. And we've seen today Rebecca and Lord Darcy and Ed all as leaders in their own right in a variety of different jobs and roles. I come from one of 26 or more organisations that within South East Coast. As an ambulance service, it's a privilege really to work across most of the organisations in South East Coast. So I'm here to talk as one of the chief execs in the community, but also one of the members of this health economy. As leaders, we've got to start really grappling with what I consider to be increasing complexity. There are significant changes, as we know and as we've heard today, in terms of patient need. There are population changes, there are changes in society, there are changes in expectation. There are also technological changes. Back in the 70s, people inside the ambulance service hear me talk of the time when we couldn't take defibrillators, which are the machines that give you the electric shock that you need when you have a heart attack or a cardiac arrest. We couldn't take defibrillators to patients where they needed them, which was in the community, because they were the size of a small family car and it took 4 people to lift them. We have got 4 paramedics here to be on hand to treat people, but they're not here to carry defibrillators. And we've now seen a change in technological advances, which means that you can have portable defibrillators that are pocket size. That technological advance is continuing, and we'll talk about some of that in just a second. We've also got what we're calling a global market, really, for professionals. I certainly know, and colleague chief execs tell me from their organisations, we see a lot more ebbing and flowing of staff now, because people recognise they've got marketable capabilities and skills. And that those skills are transferable. So there's a global market for professionals, which is making the whole job more complex. I think also the design of the system is critical. We've inherited largely an infrastructure. We know that to move to specialist centres, there's a certain amount of reconfiguration that is required. That's a complex task. We heard from Lord Darcy about the additional money that's come into the NHS, which also increases complexity. All of these things are good things. The ageing population, a benefit that we all are going to share in, increases the complexity for all of us in our roles working within the NHS. In terms of taking those drivers for change forwards, what is it we're trying to achieve? Well, the future, we must be about delivering the highest possible clinical care for patients and the public. The patient deserves nothing less, and that's what we're here for. What does that mean? Well, for us, often it means aspiring to achieve, and if possible exceed, what we call world-class outcomes. Sometimes it's difficult to find out what world-class outcomes mean, so we've got more research to do to establish actually how well people do in some of these conditions. Just within our sector, we know that from stroke, coronary heart disease and cardiac arrest, and also from trauma, we don't do as well in this country as we could when matched against centres of excellence internationally. And in order to be able to demonstrate that we're improving outcomes and we're moving to world-class outcomes, we've got to get much better at having the data, the outcome data, to demonstrate that improvement. Very often we operate in a data vacuum and we don't have the evidence base behind what we do that we need. The risk there is that non-evidence base, sometimes policies come and fill that vacuum. So we've got to be hungry for the data, we've got to be hungry for that outcome data and move to measuring the NHS really in outcome terms, because after all, that's what we're here for. Improve patient experience and satisfaction. And I guess I would include patients, carers and users as leaders in the system as well. Increasingly we're asking the public and patients what it is they need from the NHS, and that's a really good thing. And it's great to see that the South East Coast Health Authority is getting under the skin of what matters to the public, patients and staff by getting Ipsos Mori in to do some of that work. So that, again, we've got some evidence base behind what's important to people. Fair and safe services for all. I think our goal is to move to a situation where we don't have any avoidable harm or injury to patients, and healthcare acquired infections and reducing that, as we are doing in terms of C. diff and MRSA, the reduction in rates of both of those is very good across the South East. That's just the start of patient safety. Infection control is the first real step. There are many more elements to improving safety in terms of the teamwork amongst surgical staff. We've certainly seen that in the ambulance world as well, that the human factors element of what goes wrong, that the air industry understood some years ago is a key enabler to avoiding and reducing avoidable harm. So in terms of delivering that change, how do we do it? We've got to recognise and share best practice, and I think it's fair to say in the South East Coast we're not starting from a blank canvas. We've had Fit for the Future, and we've had many more discussions across the patch, which have begun to move towards identifying best practice, and I guess our challenge is to make best practice common practice across the patch. We also need to harness innovation. Disruptive technologies. Out on our stand out there, we've got something called brain acoustic monitoring, which potentially could help us in identifying patients having a stroke pre-hospitally to enable us to fast track those patients in, as Ed was saying, to CT scanning. Disruptive technologies have the opportunity to change the world, but they also have the opportunity to fail. So as leaders in the system, we've got to be better at taking more informed risk and breaking through some of the barriers that we know exist to innovation and adopting new practice. We also can't do this alone. And certainly as an ambulance trust across the patch, we're trying to work more closely with colleagues in the mental health and acute sectors. When I worked out in Uganda, they told me that there was a Ugandan phrase that meant that, as a tooth on your own, you can't do anything, but together we can achieve. And I think for me that resonates really in our work here. Development of new roles. There are lots of professional barriers to moving forwards that, again, as leaders we've got to begin to move through. We need competencies increasingly that span existing professional silos, and we've got to move forwards to continue to develop in that respect. And then finally, we need strong clinical leadership. I think we've seen recently that it's very powerful to have a strong blend of people with clinical and managerial backgrounds, and that can only be a good thing. So that's me done.